안녕하세요.
Hello, I'm Dr. Chung Young-eun. This is the case discussion to share the clinical difficulties and find the best treatment. We have three masters. Hello. For those who watch Daniel TV right now, on the right side of the video player, there is a real-time chatting window for you to post questions to us and share comments regarding the topics of discussion. The patient is a 74-year-old female. If you look at the story, implant treatment will be delivered to the upper left. How many implants need to be planned? That's the question. On the panorama, extractions are made in the upper left from 24 to 27, 35 to 37, and 45 to 47. Number 33 and number 44 show secondary caries, and the alveolar bone looks low. In the case of multiple defective teeth, we need to consider so many things, including the oral situation and economic situation of the patient. What do you think? In my view, the bone looks pretty good. In the mandible, on the panorama, alveolar bone situation suggests the patient has a history of RPD, so we need to plan the treatment based on that. On the maxilla, the bone is very good. On the mandible, it doesn't look good for implant placement. I would like to place 4 implants on the maxilla as I have private practice, and for the mandible, implant supported RPD. To be honest, I work with a prosthodontist to plan the treatment. I haven't thought about this seriously. The patient is rather old, and the patient has used RPD. I want to do minimal surgery with the biggest effect. Dr. Kim Ki-sung said he would place many implants, but I don't think so. The patient is 74 years old, and we don't need to include number 7 in the occlusion. Maybe we can do it up to number 6. Quadrant 4 would be different, so we need to consider economic and other reasons. Ask viewers to think about how many implants you would place if it were you. And if you have a very good idea, please share that in the real-time chatting window. How have you treated similar patients like this? Dr. Son? I looked at the patient and I thought about how I determine the number of implants. The basic principle is 1 implant per missing tooth. I'm a private practitioner, so sometimes I cannot keep the rule. So I consider the following factors. First, I look at the status of the opposing tooth. Natural teeth, implants, RPD, or full denture. How many molars remain in the opposing jaw, and the perio status of the antagonists. Second, expected bite force. Is it unilateral or bilateral loss of bite force? And I also consider the face of the patient. These needs to be considered. If the patient is a middle-aged man with a square jaw, I can place many implants. But if the patient is very thin and has weak bite force, we can reduce the number of implants to place. As Professor Yang said before, we need to look at the age of a patient. How long does it have to be used? Most importantly, the economic situation of the patient. Because of that, the number of implants is determined in many cases, especially when I'm talking about the private practitioners. So, one by one implant per missing tooth. That is the best. But sometimes we cannot do that. The bite force of the opposing teeth is low. There's RPD in the mandible. The patient cannot chew with the right side. I may have showed you this patient before. The ridge is very thin, so GBR is required. In this case, I use one by one. If you look at this X-ray, you may have noticed the consecutive teeth. In this case, I don't treat number 7. For the splinted implant prosthesis, number 7 and the middle teeth are vulnerable, so it may be just me. I'm not saying my approach is absolutely right, but I believe this can help to prolong the lifespan of the treatment. The opposing teeth bite force is very low, and when the right side has a proper biting capability and there is a bridge in the mandible, I place just 2 with a pontic in the middle. Actually, I use this approach quite frequently. When you place 3 implants consecutively, all alone, you would be very nervous when you place the last implant, and sometimes you find the first and second implants are too close, especially when you're a beginner. When the number of opposing teeth is small, there's only up to number 6 in the mandible. Sinus treatment is required for the maxilla, and I use a bridge here. Multiple implants are required in this patient. As you can see, the upper anterior is not good. Bilateral upper posteriors need to be treated, as well as the mandible. In this case, I treat posterior before anterior. You see many pins because I did large-scale GBR. As you can see, the number of implants is reduced throughout the mouth, so I treat up to number 6 to recover the chewing force. If you look at the case under discussion, patient is 74 years old. She can get treated under the National Health Insurance, so I will treat number 4 and 6 to be covered by the National Health Insurance. That makes me happy, as well as the patient. So when you determine the number of implant fixtures, there are many other factors you need to consider, but I hope this helps in finding the optimal number of implants. Thank you. So that was a brief comment on my part. As for me, as I said before, I'll talk about how to approach the case rather than the treatment planning. I look at the patients in 2 different perspectives, whether the patient is a perio patient or not. Dr. Song gave us very good explanations. The patient has multiple caries and dental phobia. The bone is very good, and she's in her 40s. in mid-40s. Considering the life expectancy, implants can be placed as many as possible, one by one. So that was the principle. This is the overall situation. From number 4 to 7 were placed, but for upper 7, sinus was perforated, therefore it was delayed in terms of the placement. So up to number 7, many implants were planned to be placed with the spaces for easy maintenance. This was the restoration plan. However, this is a different patient. Multiple losses are observed, and at a glance you can see the advanced type of periodontitis, and the patient is heavy smoker and poor hygiene. At the beginning, I tried to save as many teeth as possible, but as it went on, it got aggravated, and the alignment of teeth was not very good. So without extracting, we decided to improve the alignment. Pictures taken by orthodontic department. Initial treatment was delivered. Now the situation is different. Quadrant 1, number 4 and 5 were extracted and alignment got better. Various options were used. From number 2 to 6 are missing. So how to restore that portion? I discussed the matter with the prosthodontist. This is a young patient, so we need to treat all of them. But the biggest factor is the economic factor. Compared to the local dental offices, our hospital charge more, about 3 times. So what is the optimal solution for this? As you can see, the reach was pretty good. So we would do small scale of graft and prosthodontist planned 2 bridges. Prosthodontist is very good at this. This is the form. So it was treated from number 2 to 5. As you saw before, at number 2, the bone is deficient. In general, we would do GBR, but due to patient's economic reasons, we couldn't do that. Pontic and the cantilever were planned. Prosthesis and ortho treatment were not completed, and we will consider the ease of maintenance. The patient is a young man, so it's not simple. There is a problem whether the prosthesis can withstand the force of bite force. So rather than 1 by 1 implant placement, a bridge, as long as it can withstand the bite force, is more favorable in terms of the maintenance of the treatment. We need to look at the cause of the extraction. Is it because of the caries or perio problem? There is a difference. Let me add to that. As a person who has a lot of prosthodontic thinking, in this patient, the perio is not very good, so extractions were made. Only 6 anteriors remain. Depending on the opposing teeth and the patient's capability to pay, it may be different, but basically, I think for proper placement of implants, we need to place 1 implant per tooth. That's because I have a private practice, and to solve prosthesis problems, connecting many prostheses is not good, and it is too cumbersome to separate each of them separately. We can connect the 2 of them together. Ultimately, I want to place 1 implant per missing tooth. and connect them, two of them together, or if I place three, I can connect the two of them together. If a food infection occurs later, we don't have to remove the prosthesis altogether. Ideally, four need to be placed, but we cannot always do that. There are opposing teeth and natural teeth, so I could place four of them. Also, cost-wise, private practitioners charge less than university hospitals, but we cannot always do that. Sometimes, the number of implants needs to be reduced. In this case, 5 were placed, 1 implant per missing tooth. This can be problematic when period problem occurs later. For internal conical type implants, if you place it properly, it tends to have less peri-implantitis. 5 look many, but it was placed one at a time. That would be ideal. However, depending on the opposing teeth situation, a partial denture is used. In this case, instead of 4, 3 implants can be placed in the posterior region, and you make the prosthesis not 4, 5, and 6. It is instead 1 premolar and 2 molars. I think that is reasonable, and I tend to do it that way. When we place multiple implants, we make premolar and molars mesodistally. But my idea is if there's no prosthodontic guidance problem, we make a prosthesis not just normal premolar, but bigger premolar and smaller molars. So I made 3 of them here, like this. That was possible because there is a partial denture on the antagonist side. As you look at the case under discussion, if 4 teeth are missing, there are many options. If you look at the slope at number 3, cannot place 4, so 3 were placed and 4 prostheses were made. Where do we need to position the pontic? At number 4, the pontic cantilever is made. The 4 prostheses need to be connected. When you do that, it looks simple, but when one of the prostheses creates a problem, repair could be quite challenging. So it looks simple, but in terms of the long-term prosthesis maintenance, it can be hard. 3 are placed and 4 prostheses are made, and the pontic is at number 5. The prosthesis can be connected all. Sometimes I connect the 4, 5, 6, and 7 is left separate. That's good for prosthesis repair. There are many different options available. In this patient, 4 were placed at quadrant 1. At quadrant 2, 1 is missing because the bone environment is not favorable. Depending on various variables, we need to consider the number of implants, but in principle, 1 implant per tooth. Here are 3 implants and 1 pontic. Many different options. One of the most frequently used options, as they showed, at number 4, an implant is placed. 5, 6, and 7 are connected with a bridge. This is commonly done, and the pontic is at number 6. I don't do it like this often. When food infection occurs between number 3 and 4, you can treat the number 4. That is good. However, in this case, there is a sinus, but usually number 6 is a good location to place an implant, and we have wasted the space here. And this can reduce the cost. As Dr. Son said before, if 4 are missing, 2 are placed. Depending on the pontic location, it would be different. but I have done this. However, two are placed and two are treated with pontics, as was discussed before. Right now, the cantilever looks okay. However, later, the opposing teeth situation can be changed, breaking the equilibrium, and one side can be overloaded. In this case, 4 were placed and 5 prostheses were fabricated. It was cut in the middle, separating 3 from 2, like this. Prostheses from the repair perspective need to be separated. If you have enough number of implants placed, you can adapt to the changing environment in the antagonist side. Excessively 5 were placed when 4 were extracted. This is an old case. In the past, we talked something like we need to place 1 implant per root in the posterior region. When I was learning implantology, my junior alumni came to me to help place implants. Number 6 and 7, 3 were placed, and 4 and 5 got lost, and I placed 2 of them there. And here, 6 and 7 were missing and 3 were placed. In this case, I don't know why, but the middle implant tends to fail often. I don't agree with this. Implants need to have some distance. This is not good either. 1 implant per missing tooth, so 5 were placed, but that's too excessive. The path of a prosthesis was not considered, and some implants are too close with each other. Quadrant 2, I placed the implants. We need to have some distance between the implants. As long as that can be respected, 1 implant per tooth can be better. The environment in oral situation differs from patient to patient. We need to expect the occlusal force equilibrium can be broken later. We need to consider that in advance. Thank you. I have a question. In our hospital, we charge more for the implanted treatment than private practice. Although we recommend that many implants to our patients, they don't always accept that many. It would be better to have some more room. For example, in quadrant 2, when 4 are missing, we recommend 4 implants to be placed, but the patient accepts only 3. How do you design that? I don't do the design. I make the patient do the cost design, and I offer the last one at very low cost. If you connect them in a bridge, periodontally it's good. According to recent papers, when 3 teeth are missing, the best outcome was achieved when 2 implants are placed and connected with a bridge. But I cannot believe it. I don't think it's reasonable. As a periodontist, does it make sense? We have a series of papers. These days, if 3 implants are placed in a row, the middle one tends to have periimplantitis, higher morbidity there. I would like to study that in more details. I want to see whether 3 of them are connected together or just 2 of them were connected. I think it makes difference. I presume in the past we used more external type implants. With such implants, the middle one is affected by the load most. And one more thing I can presume, in the paper, I don't think there are many screw loosening papers. As a prosthodontist or private practitioner, where do you experience the screw loosening more? I believe those are the influencing factors. Here we are talking about the internal connection, and this would be a different matter, but we need to shed light on those. You place the 3 implants, do you connect the prosthesis all together? Sometimes yes, sometimes one single and 2 posterior can be connected. When 3 are connected, I experienced often the middle one creates a problem. If we place the 3, tripodism should be achieved according to the old textbook. The second fixture tends to be placed buccally, leading to the thin buccal bone. I try to keep that tripodism at the beginning, but I don't think that is the problem. The middle one creates problem when 3 are splinted. I believe the problem occurs for both internal and external types. And in some cases, I had to refabricate prosthesis. So I really wonder the reason why. Many doctors, and including me, when 3 are connected, middle one creates a problem. Maybe a lot of load is applied there. I used to do that, but these days I tend to separate them for prosthodontic reasons. Recently, in our study group, we had a discussion. When 3 are missing, 2 need to be placed, and some people said it is not right. Periodontists believe that is correct, but I don't think that helps to resolve the prosthodontic complications. Periodontists or others emphasize the bone level. When 3 are placed, a bridge using 2, the bridge has more stable bone. In terms of the prosthodontic complications, I'm curious where you have that complications often. When you have less number of implants, they get more load each. The internal type would have much more screw loosening due to the abutment sink down phenomenon. This leads to the problems of the internal type, the fracture of an abutment or an implant. So that's a different problem from the external type, which was discussed in the old papers, and the connection type makes a difference. This is a different story. One of the textbooks in periodontology, Dr. Linde described a different treatment plan between edition 4 and 5, whether you need to restore up to number 6 or number 7. I believe the textbook is about foreign cases. In full mouth cases, the restoration needs to be made up to number 6, and 6 implants were placed using a bridge. Before we came here, we discussed about this. The description is about foreign cases, and we said maybe among Koreans it would be different. So we don't have to rely on foreign textbooks. We need to shed light on that by setting up Korean treatment plan through writing papers. Dr. Kim Ki-sung, in this case under discussion, do you place 4? Yes, if possible. I say to the patient, you are 74 years old and our life expectancy is 100 years old, and they get persuaded. I think that's good. I need to learn how to talk to the patient from you. It was a good discussion. Regarding this case, do you have anything further to add? From Korean's perspective, missing number 7 is regrettable. Many papers in other countries talk about treating up to number 6. We'd better treat up to number 7 for long-term prosthodontic perspective, not periodontal perspective. From the maintenance perspective, the biological complications are far more frequent than the mechanical ones. From that perspective, I'm on the side of a periodontist. So I aim to reduce such complications by placing far fewer implants. That's what I think. I agree with Dr. Kim in terms of the concept. In order to lower the entry barrier, I would recommend the 4 and 6 positions for implants to patients. Once the patient comes into the realm of implantology, we can go further. By providing steady maintenance service, I try to persuade the patient to receive more implant treatment. In this case discussion, we talked about how many implants need to be placed when multiple teeth are missing. I would like to thank the dentists who raised the issues to be discussed. Thank you very much. Thank you. This concludes the case discussion. I am Dr. Jung Young-eun. I'll see you next time. Thank you.
수고하셨습니다.